Welcome, everyone. We're just going to give folks another 30 seconds or so to join today's webinar, but start shortly. All right, well, maybe I'll go ahead and begin with some introductory remarks, and then in the interest of time, and then we'll, I'm sure while I'm giving those remarks, to have a few others trickle in. But welcome, let me just welcome everyone on behalf of the Berman Institute of Bioethics to today's webinar, part of our seminar series in bioethics, during which we invite colleagues from around the US and the world who are doing really interesting and cool stuff in bioethics to share their work with their community and have a conversation. And I'm really delighted today to have the honor of introducing our speaker, Dr. Peter Ubel. Dr. Ubel is the Madge and Dennis T. McLaughlin University Professor of Business and Public Policy and Medicine at Duke University. He's a physician and a behavioral scientist, using multiple different sorts of tools and methods in his work. And he's obviously very accomplished in his scholarship and in his own practice, and has authored numerous academic publications, texts, a number of them exploring empirical issues involving decision psychology as it pertains to healthcare, as well as issues around the intersection of economics and bioethics and health. So we're honored to have you, Peter, today, and welcome you to give your talk, which is entitled Sick to Debt, Fixing Our High Out-of-Pocket Healthcare System. I'm keeping it brief just so we have as much time as possible to hear from you and to have a Q&A and discussion. Let me just say, by way of the Q&A, that if you do have questions, as usual, please do drop them into the chat or the Q&A, and I'll be following them throughout, and we'll have an opportunity after about 30, 45 minutes of presentation to take those. So yeah, welcome and thanks again.
Thanks, Joe. And I'll ask, actually, if people have clarifications, if I say something in a particularly confusing manner, maybe just put the word clarification at the front of your comment and then send it in. Then as Joe's looking at it, he might be able to jump in faster if I just said something really, really awkwardly or something. And I'm going to actually start off with a question for you. And here I do want people to put something into the chat function, because I'm curious to see what your take is on this question. And the question is this: if you had to implement one healthcare policy in the United States that would better empower patients, in a sentence or so, what would that policy be? And Joe, as different ideas come across your desk, I guess,
yep,
let me know what people are saying.
Sure.
Oh, I see free childcare. I actually saw that one.
Mm-hmm.
That's interesting. To empower patients. So I'm thinking within the healthcare and how to empower patients. Anything else? I know you're a very shy audience. Universal EHR with a patient portal. Oh, okay, yeah. So really let people see their medical record more easily. That's a good one. Universal EHR, they'd share more easily across where you receive care. That's a great idea.
Looks like
I'll wait for one or two more ideas and then I'll move on.
We have a national HTA body as well, National Health.
Okay, great. And better information on the cost of healthcare and transparency and prices. Fantastic. So those are all great answers. They're all wrong answers. And I'll tell you in a minute, well, I'll tell you right away why they're wrong. Before Donald Trump was elected president, the House of Representatives, 2 Republicans in the House of Representatives, put forward some legislation, didn't get passed into law, that was designed to empower patients. One was called the Empowering Patients First Act. Not sure what was going to be second. And another one was called the Patients' Choice Act. One was authored by Paul Ryan, the former Speaker of the House, another by Tom Price, the orthopedic surgeon who became the head of Health and Human Services under President Trump, but was at that time serving in the House. Both of those pieces of legislation had something in common. They planned to empower patients within the American healthcare system by exposing them to higher out-of-pocket costs, based on the idea that this would, by facing higher out-of-pocket costs, people would be empowered to act as healthcare consumers, better scrutinizing the cost and quality of their care, and thereby receiving lower price, higher quality, I almost said lower quality, higher price, higher quality care than they otherwise would have. So that was what was in common to those. And I'll talk a little bit more about the theory behind that. And that's what we're going to be visiting. But before I go into theory, schmeary, or anything like that, before I present data, I'm going to present anecdote, because we all know the plural of anecdotes is data. And so I will maybe give you a couple anecdotes. So by the end of the talk, you can't say this was a data-free webinar. So this is a true story of a man, Chris, I won't say his last name, who was 39 years old, working in a trucking company in North Carolina, when he had blood in his stool, got that evaluated by his primary care doctor, got some follow-up tests, and eventually ended up at Duke University with the diagnosis of stage 3 colon cancer. That would mean that the cancer had, and I'm probably going to get this wrong, it had not distantly metastasized, but it had invaded the wall of the colon. The oncologists and medical and surgical oncologists at Duke felt this was dangerous, potentially life-threatening, but also still potentially curable. And so they designed a plan of attack. By that, I'm going to avoid that metaphor. They decided that they would start with chemotherapy. He ended up taking pills for that. But that would shrink the tumor, make it easier for a surgeon to go in, remove the entirety of the tumor, repair the colon in whatever way it needed to be repaired, and then basically reevaluate and see if they could move towards a cure. So Chris went through the chemotherapy, got really good news when follow-up imaging tests showed that the tumor had shrunk, went into the operating room, came out, the operation had no complications, went back to meet with his medical oncologist, a man named Yusuf Zafar, a really good friend of mine. And Zafar broke into tears telling Chris that his cancer had spread to his liver, that they found that out in the operating room and that hadn't showed up in the imaging tests. That meant he went from stage 3 to stage 4 cancer. There is no stage 5. That meant he went from potentially curable to incurable and likely life-limiting. And so the oncologist was despondent, as was Chris. And they had a very difficult discussion about what that would mean. And then trying to turn things towards more positive, Dr. Zafar told him, well, look, Chris, we can put you back on the chemotherapy you were on before. Your tumor responded well to that. If it responds again, we can slow this down. And who knows what treatments will be around the corner if we can just slow this tumor down long enough. To which his patient, Chris, said, I'm not going back on that chemotherapy. Well, why? You didn't have any side effects. He said, no, I did have a side effect. I spent my life savings. He had basically gone to the verge of bankruptcy, paying for that chemotherapy. So that's already disturbing, that he faced that kind of high out-of-pocket costs, despite having insurance coverage, despite being fully employed at the time. What made it even worse is that Dr. Zafar, his oncologist, had prescribed him a pill because he thought it'd be more convenient for Chris to take the pill every day at home, rather than an equally effective chemotherapy he could have had, where he'd have to come to the clinic. I'm not sure if it was once a week or more often than that. I don't know the frequency, but he'd have to come into the clinic for infusions and get the medicine put right into the vein. And so just to make it more convenient, he gave him the pill. It turns out, because the pill comes out of the medication portion of Chris's insurance coverage, he was on the hook for a lot of that. If he'd come in for those infusions, that would have come out of the medical services part of his insurance. It would have been way more generously covered. Dr. Zafar had unwittingly bankrupted his patient, giving him a chemotherapy when he could have had an equally good chemotherapy that would have cost him little to nothing. Terrible, tragic, and quite ironic, because Zafar is one of the world's experts on the financial toxicity of oncology care. He's probably thought as much about this topic as any oncologist on the planet, and yet still, in taking care of this one patient, forgot to check on what his out-of-pocket costs would be in time to inform the medical decision. So I told you a little while ago that when a couple people in the House of Representatives wanted to empower patients through legislation, they thought the best way to do that would be to direct more Americans towards high deductible health plans, higher out-of-pocket health plans that would give people an incentive to scrutinize the cost and quality of their care. When you get medical care for free, after all, no reason to think about what it costs because it doesn't cost you anything. And so maybe you should still have an incentive to look at quality, but if it's higher price means higher quality, or you assume higher price means higher quality, you don't even care to scrutinize that. You just take what they offer you and don't think as much about it. The idea with high deductible health plans, one idea of what them is, people will be like, oh my gosh, it's gonna cost that much. Let me look to see if I really need it. Are there alternatives? I think Chris's story already belies some of that myth that these high out-of-pocket costs empower people, because here was a man who literally spent his life savings. And if he had been incentivized to scrutinize cost and quality of care, presumably he would have recognized there was an alternative to chemotherapy just as good and much less expensive. But of course he didn't, because he's a patient who's desperately ill and who's relying on an oncologist to give him advice. And the oncologist forgot to check the price. Now, it might sound really naive to think that anyone would think you empower people by giving them a high out-of-pocket cost, but let me cut through that naivety for just a second. First, there's a lot of economic theory that backs this up. Markets are a good way to get low price, high quality goods. Consumers really can discipline markets by scrutinizing cost and quality. There's evidence through what we call moral hazard that when people get medical care for free, they tend to demand more than they otherwise would, even to the point where it's not money well spent. I also, just because this is an ethics seminar or webinar, the idea that people can be empowered to make these kinds of really difficult choices in life isn't all that far afield from what has really been behind a lot of bioethics, which is doctors should stop telling people what to do. They should give them all the information they need so they can decide what they want to do. We empower them with information and freedom and choice. And through that process, we respect their autonomy, and then they make these really good decisions, ensuing decisions. That's something I hope in the Q&A we can maybe explore in a little more depth. How much is there an overlap between standard economic theory and really some of the most important theories of bioethics? Now, in addition to just seeing people in high deductible health plans because there's economic theory to back it up, there's also been a real push to get people into high deductible plans because it saves money. And who does it save money for? Well, for employers, for one. There are a lot of employers now, about a quarter of employers in the United States right now only offer high deductible health plans to their employees. Another quarter plan to only offer high deductible health plans in the future. When you're only offered one choice, that's not much of a choice. The employers, by having more of their employees in high deductible health plans, find that the people are less likely to demand medical care, which saves the employer money because they demand less medical care. Second, because more of the medical care is paid for out of pocket, it saves the employer a second time by having some of that cost borne by the employee. So a lot of the impetus for increasing high deductible health plans in the United States is to save employers money. Last I checked, about more than a third of Americans are in high deductible health plans right now. And I should say, Medicare isn't very far from a high deductible health plan for many people. The average Medicare recipient who has breast cancer faces something like more than $5,000 a year of out-of-pocket medical expenses because of that diagnosis. So Medicare is far from a low out-of-pocket system for many people, especially if they can't afford supplemental insurance coverage. Okay, so I told a little bit about the theory backing up the move towards high out-of-pocket medical care in the United States. I've talked about how that's becoming a more common way that people receive their coverage. Now I'm going to do two things. I'm going to spend some time showing the problems with that theory. I think how it's off base about how people make medical decisions. And then second, rather than just being all negative here, I'll try to suggest some things we could do to reform the way we design health insurance in the country. And I think better help support them for important medical decisions they have to make and not leave them with the tab for medical care they need. So that'll be my goal. Okay, so next part, then I'm going to tell you why I think the theory of empowering people through high out-of-pocket costs is misguided. First, it assumes that people who choose, when they choose insurance plans, that they choose them in part based on their goals and preferences as a health insurance consumer, and that they understand the insurance well enough to make these really rational choices about, do I want to be in a high deductible, medium deductible, low deductible, and no deductible plan? Turns out, and I've done work with Mary Polity from Washington University in St. Louis. Mary led this work, she's fantastic, where she did a study surveying and interviewing people, low-income residents of St. Louis, and trying to help them choose health plans through the health insurance exchanges of Obamacare. And as part of that, she tried to educate people about what it meant to be a deductible or a copay or a co-insurance. For those who don't remember off the top of the head, co-insurance means that perhaps I have to pay 10% of the cost of something, that the co-insurance rate is 10%. So even though I've paid my monthly premium, I still have to pay 10% of my hospital stay or my meds or something. That'd be co-insurance. After giving people a definition, trying to help them understand it, she then asked them what it meant. And many people said, oh, that's another insurance I get. It's they thought co-insurance meant supplemental insurance. After defining and trying to describe what a deductible was, she still found that many of the consumers thought deductible was what you deduct from the cost of insurance. So the higher the deductible, the better, all else equal. When of course, the higher deductible means you're on the hook for more money. So they got it backwards, totally understandably. Deducting is usually good if you deduct the price from something, but the terminology is often inscrutable to people. And so now you give them a bunch of information about 5, 6, 8 insurance plans to choose from, or even 3 just that your employer offers. And when you have a hard time just remembering what a deductible is and what a co-insurance is, and doing the math of monthly premium to multiplying them by 12 to see what that means for annual premiums versus the cost of the deductible. I mean, it's so easy for people to be overwhelmed and confused that it's kind of naive to think they're going to just make amazing choices in that setting. The second is that even when you try to help people make better choices, that doesn't necessarily help. When the state of Massachusetts, under Romney Care, the predecessor to Obamacare, when they gave people an ability to buy insurance on health insurance exchanges, to simplify the choices, they put them under gold, silver, and bronze plans, just to say, don't have to look at 15 plans. Do you want gold, silver, or bronze? Define what those were. And then if you chose gold, you might see 5 plans instead of 15, and you could choose among the 5 plans. So they tried to simplify it a little bit. But it turns out, and gold plans tended to be high monthly premium, low out-of-pocket costs, and bronze were low monthly premium, high out-of-pocket costs. I have to make sure I don't get that backwards. So it turns out the right choice depends on whether you're really healthy, at which point you might want to spend less per month and be willing to take the risk of out-of-pocket costs. If you've got a chronic illness in you or your family, you might buy the gold plan that's more per month but less out-of-pocket. So that's how you'd rationally choose. We did a survey, and this is with Dave Comerford, a behavioral economist, a colleague of mine, where we gave people bronze, silver, and gold plans. Oops, I just changed the order. And asked them to choose, well, if you were picking right now, which would you do after we gave them a definition? And then for half the people, we flipped what we called bronze, silver, and gold. And it turns out for people who weren't particularly good at math, below median in their mathematical ability, they just wanted the gold plan, whichever it was, whether it was high monthly premium or low monthly premium. They just knew that gold is a better metal to win than silver or bronze. I mean, they've watched the Olympics. And so even trying to make it easier for people to make these choices, we might lead them astray unwittingly. I'm going to give you just a third example of this and move on to another phenomenon. When under the Affordable Care Act, when you go to a shop for insurance on the exchanges, they give you a bunch of plans to look at, and they typically order them from lowest monthly premium to highest monthly premium as you scroll down the screen. They have to order the plans in some manner. You can't look at them all simultaneously. But it turns out when we've done research where we flip the order of the plans, where we start with either low monthly premium and you scroll down to get the high monthly premium, or high monthly premium, you scroll down to get low monthly premium, that the order we give you the plan will determine which plan you choose, independent of what the attributes of the plan are or what your particular preferences are. So I'm just gonna stop at that point now and just say, problem number one with the idea of empowering consumers through these kind of insurance plans is we can't expect that people are choosing the plans knowing what they're getting. And so that's not really empowering them to make good choices when they don't even understand the plans. And that means when they get high out-of-pocket cost plans and don't know they face high out-of-pocket costs, all they end up is with a surprise bill rather than an informed consumer choice. Second thing, and this reflects two of the comments that people made in the opening chunk of time, and that is problem number two with consumer-based healthcare decision-making is price opacity. It's really hard to find out healthcare prices in the United States, even today, and we've been working on this for a couple decades now. There's huge price variation in the United States. You can get a hip replacement at a reputable American medical facility now for $20, $25, maybe $30,000. It's a lot of money, but you can also pay $100,000, $120,000 at a place. So while most aren't as high as $100,000, there's a lot of $40,000, $45,000 hip replacement procedures vying or competing against $25,000, $30,000 hip replacement procedures. So there's a lot of price variability that should motivate people to look carefully at prices, but it's really hard to find those prices out. One of my former students, Pete Cram, who's now in Toronto, he got a bunch of his research assistants to do a secret shopper study where they called up hospitals around the country, random set of hospitals, said they were shopping to help their grandmother get a hip replacement, and she did not have insurance. So they wanted to get a price so that they know what grandma would pay. They got full price information from 10% of the places they called. They got partial from about half of the places. And the other half, they could get almost no information from them about what it would cost for someone to get this kind of procedure. So even making multiple phone calls and being very persistent, it was hard to find price information. Now, of course, phone calls are an old-fashioned way of getting price information. Now you go and you Google for prices. So I got a team of undergrads, and we worked with Allison Kratka, who's now an internist at Harvard. And Allison led this group of undergrads to Google for the price of things, where we would just get online and say, what's the price of an upper endoscopy in Topeka? And we found a lot of ads, and we found a lot of irrelevant information, and we had a very hard time finding price information. And when we found one or two prices, we almost never found a simple place to go, like if you're getting an airline ticket or buying a microwave oven, where you could compare the price of multiple options. Why are prices so opaque in the United States? In large part because prices are set by negotiations between insurers and healthcare providers, hospitals or clinics and physicians and such. And because every insurance company and say hospital have a secret negotiation, they don't want other insurance companies or other hospitals to know what the result of that negotiation was. They've tried to keep the prices in the dark. It actually took years of litigation before some of those prices came out into the open. And even to this date, it's hard to find them easily in most places around the country. Okay, so that's the first two problems. People don't understand their insurance. When they end up in high deductible plans, they can't find out the prices of things in time to inform the decisions they make. A third problem is really, who is the consumer, who's the decision maker in healthcare anyway? And here I'll just quickly summarize a study that we did with Angie Fagerlin, who's now at the University of Utah, where we audio recorded men with early stage prostate cancer while they spoke with their urologists, the surgeons, to decide how to treat that cancer, which for most of them could mean active surveillance, where you just monitor the tumor closely and frequently to see if it might begin to grow, surgery to remove the tumor, radiation to eradicate the tumor. The active surveillance leads to a lot of follow-up testing, and then the anxiety of living with a cancer in your body. The surgery and the radiation typically lead to high risk of urinary incontinence, erectile dysfunction, and arduous procedures that you've gone through. No right or wrong choice. It depends on what a man thinks of that trade-off. So we audio recorded men talking to the urologists about this decision. In all those cases, we'd given men a prostate cancer decision aid to help them weigh the pros and cons of this. This was just informed consent, shared decision-making 101. We gave people the information that they could then incorporate with their own preferences, goals, values, to help decide what would work best for them. And we had urologists on board with the idea. They knew that the patients got a decision made. Their goal was to help patients make that decision. what we found is that when we measured what people said they wanted before the visit and what they got after the visit, we found no correlation. We couldn't predict what treatment a man got based on what he said he wanted to get before he saw the urologist. Instead, the things that predicted treatment choice maybe in quotes, was how old the man was, whether it was an early stage or kind of early stage cancer, and then most strongly, what the urologist recommended as a treatment. And when a urologist said, you need to get this out, people typically got it out. And so regardless of what they thought about the side effects of those treatments, they trusted their physicians. And so that just is a reminder that medical decisions are not the same as somebody buying a cell phone who doesn't go to some cell phone expert to ask and rely upon their advice while they're scared and worried for their life and well-being. You shop for phones, you didn't like the last one you got, and you try a different kind. You talk to some friends and things like that. In medicine, often, especially for high stakes decisions, people are scared, they're underinformed, they're trying to absorb as much information as they can, but in a very stressful situation. And they often rely on clinicians for expert advice and guidance, and that often is quite influential. And these are clinicians who have their own biases that they're not always aware of, that have some financial conflicts of interest that even if they're aware of them, they may not be aware of how they're influencing their choices. And so it's a pretty unusual consumer domain. Okay, problem 4 with this idea of consumer healthcare decision-making is how difficult it is to talk about out-of-pocket costs when you're meeting with your, say, physician. A lot of these decisions might work better if, like in the opening story, when this one gentleman had cancer, if his doctor was able to say, here's the price, and in fact, let me help you factor those out-of-pocket costs into what we know about the other harms and benefits of these therapies and what they would mean for your medical well-being. But it turns out it's often hard for physicians to hold these conversations. In part, they've not been trained to do it, how to do it. Second, it's hard to find the price information. So why start a conversation you really can't have a satisfying conclusion to? And third, some feel like it's not even appropriate for them to talk about money. They don't want me to be, they're worried for their lives, and it would be harmful for me. It might be mean-spirited, it might even be unethical for me to be worrying them also about their finances. I'm happy in the Q&A to talk about whether that's a reasonable moral opinion to hold. I understand where it comes from. I largely disagree. And I think, but I think a lot of physicians want to hold these conversations, and it turns out whether they want to or not, they're being forced to because it's coming up frequently. In a study that I conducted with the help of a company called Verilog that does marketing research, and the marketing research it does is through audio recording physician-patient interactions, again, with permissions, with all the information de-identified, transcribed, et cetera. I was able to get a hold of a couple thousand doctor-patient interactions and look to see how often did healthcare costs spontaneously arise in these visits, because that wasn't the focus of any of these conversations. And what happened when those came up? And it turns out about 25, 35% of the time, cost comes up in a visit. And so it's not a rare conversation, a rare topic to come up. And sometimes it leads to very productive conversations about understanding someone's out-of-pocket costs, navigating out-of-pocket costs, looking for alternatives if those are possible, or even looking for better coverage or better financial assistance when there aren't good alternatives. So that's all fantastic. And then other times it leads to really unproductive conversations. I'm going to quote just a few, and then we'll move on from there. One patient came in who had rheumatoid arthritis and was needing a medicine for stomach acid pain, and said to the doctor, I know there's a new thing for the ulcer besides the Nexium because that drug is so expensive. And the doctor says, not necessarily hearing what the patient said, never discusses the ulcer drug, and then says, did we use the methotrexate for your arthritis? And switched the topic to the arthritis pill rather than ever getting to the antacid pill. That means the patient was left with the expensive pill and no help affording it. There are very inexpensive acid pills around. Another example, a patient came in, this is a patient with breast cancer, said, I'm drinking a nutritional supplement every day. The doctor says, I imagine typing, but I try to stretch it out because the supplement is a little expensive. says the doctor typing. Anyways, I'm developing anemia, says this malnourished patient. I'm having to eat high protein food right now. Drink some protein drinks. Protein, okay. And that sort of thing. Oh, okay, says the doctor. Let me take a look at this spot. And then never returns to the topic of the unaffordable nutritional supplement. This is a woman, losing weight from cancer, having a hard time keeping that weight up and not able to afford basic nutrition. And the doctor maybe was so busy typing that he or she did not notice that this person was suffering from financial distress. It's tragic. I saw a number of times where a patient would come in, complain about the cost of what out-of-pocket cost of one of their treatments or medications or something. And the doctor, instead of helping address the out-of-pocket costs, would simply criticize insurance companies or drug companies for making so much money. And then they'd all vent about how evil all these entities are, and no one would get back to the out-of-pocket costs. I saw other visits where one patient was needing a BRCA genetic test to explain the breast cancer that she had. When she asked the doctor how much the test would cost, the doctor said, "Oh, we don't want to talk about that." She did want to talk about that. And then finally, there was a patient who had pain from metastatic disease to her bones, complained about the price of OxyContin, a very expensive long-acting narcotic. The doctor just told her maybe if she took less of the medicine, it would cost her less money, not in a heartless way. I didn't mean to suggest any kind of tone of voice. But the doctor never explored other much more affordable long-acting narcotics. So that's a real missed opportunity. So I'm going to give one more example of where I think healthcare consumerism suffers, and that is end-of-life care. That money, even if we all knew what insurance we had all the price information at our fingertips we needed, we knew all the cost of all the independent alternatives, at what point do we feel like we have a choice? I interviewed a man who had head and neck cancer, and the radiation treatment to his jaw and neck area led to the destruction of his salivary glands, which then led to the destruction of his teeth, in which he had $1,000 per tooth for having the teeth extracted and the infections treated. All of that the money was discussed up front because the dentist knew that the person would pay out of pocket, and the patient never felt he had a choice. Sometimes in medicine or dentistry, the stakes are so high, it's really hard to think we're in a position to negotiate prices, and it doesn't feel like we have the option to say no. It's not a very normal consumer market. I can say no to a Lexus or an Audi. I can't say no to having a painfully abscessed tooth taken out of my mouth. So that's some of the problems with consumerism. That's why healthcare doesn't work like traditional consumer markets. So let's try to help make these markets better. And I'm going to go through this fairly quickly so that we have time to debate it, discuss it, explore it in the Q&A. And what I'm going to tell you is I'm going to give you a recipe, almost not a recipe. I'm going to give you a set of ingredients that you could use to improve the way we deal with out-of-pocket costs in the United States. But I don't know what recipe to use. I don't know how much of one or another to use. But I think these are the kinds of things that might make for a fairly appetizing meal or a fairly improved system. The first is we have to recognize that nobody's being empowered to pay out of pocket with money they don't have. In Singapore, which has a much more out-of-pocket healthcare system than we've traditionally had in the United States, the government actually mandates that some of people's earnings go into health savings accounts that they use year to year to pay for medical care, that they can carry over year to year, that they can even pass down to their children when they die. And for people who have very low income or who are unemployed, the government actually puts money into that kind of a savings account for them. I think it's the legislation I've seen that has tried to push people towards high deductible health plans has not found a way to make sure that they can have the money to pay off those deductibles. That doesn't seem fair to me. The second is we definitely need price transparency, as a couple of you mentioned up front. We can mandate that at the state level for sure. That can be done. Federal level, who knows, we can do anything. But the state of New Hampshire actually has a law that requires hospitals and clinical providers to have their prices out there, not just Medicare prices or uninsured prices, but Aetna and Blue Cross, etc. They put together a website, and I actually suggest when we're done, maybe check out the New Hampshire website for looking for healthcare prices. It's elegant. You can sort by price, you can sort by alphabet, you can sort by distance from where you live, and it'll very simply and cleanly tell you how much you'll have to pay based on your insurance coverage for any given service. So that's a second change. Third change I'd say is we need to rethink out-of-pocket costs. This is an idea championed by Mark Fendrick at Michigan and Mike Chernow at Harvard, called value-based insurance design. And the basic idea here is those out-of-pocket expenses people pay, let's call it copays. They shouldn't just go up when the price of something goes up. I have two medicines, one's less expensive, one's more expensive. The typical thing would be, well, charge more for the more expensive medicine than for the less expensive medicine. What value-based insurance design says is ignore the price. We want to know about the value, and value is price and benefit. And so something that's high price but very high benefit could be very good value. Something that's low price and no benefit would be terrible value. And so a VBID plan, value-based insurance design, would say, if this is a high value intervention, it should be low to no out-of-pocket costs. If it's a low value intervention, most of the cost of that should be borne by the patient. And then in between, you dial up and down the copay accordingly. I think that's just a much more rational way of designing out-of-pocket costs. There's another way that people have talked about redesigning out-of-pocket costs. It's called reference pricing. Return to the hip replacement example I discussed earlier, where prices range from 25, 35, 45, 55,000 and more. The state of California recognized that many of its employees, when they needed hip replacements, were going to the $45,000 hip replacement joints, where there was no evidence that there were higher quality providers than the ones that were charging 25, 28,000. And so what the state of California did was it surveyed the landscape, saw that there were plenty of very good providers that were $30,000 or less for that procedure, and told the state employees, you can get a hip replacement anywhere you want if you need it. We're going to give you up to $30,000 to pay for that. And if you go to a place that charges you more than $30,000, the difference will be on you. There were two results of that. First is people started shopping for price. They tended to preferentially head towards the less expensive providers. And the second is many providers that used to charge $38,000, $42,000, $43,000 magically came to a $29,000 price so that the patients could get it affordably. So it changed consumer choice and it changed provider pricing. So that's called reference pricing. I think it's very powerful. People have used it even for medication formularies. Private employers have used reference pricing too. It isn't just something the government does. I'd love to see more of that. Next change I'd recommend, next ingredient here in this recipe is just simpler insurance design. Right now, when Obamacare came in, became a law of the land, and they were trying to figure out how many taxes they needed to do to pay for the law, things like that. And they knew that people would be choosing between bronze, silver, gold, platinum plans and the like. In pricing out the legislation, they built into that the idea that a decent chunk of people would make unwise insurance choices, that some very healthy people would end up in high monthly premium plans because they were scared off by out-of-pocket costs, even though maybe they shouldn't have been. The unwise choices were baked into the math of the plan. And for all the reasons we saw earlier that people don't understand insurance, they're going to make bad choices. And that's why I think we should radically simplify insurance design, give people fewer choices in terms of how they vary by out-of-pocket costs. I'd actually think we should get rid of high deductible health plans altogether because they tend to dissuade people from getting necessary care and to delay important and urgent care, and with no evidence that they improve people's decisions. And so I don't think that those deserve a place. Finally, I'm going to talk about creativity for end-of-life spending, and I'm going to just go to a socialized system for this example. And then we'll be able to wrap up and we can have a good question and answer session. So the United Kingdom, again, socialized healthcare system, has been looking at rising cost of end-of-life care, just like we've got here in the United States. And you can address that in part through price controls, which is not an issue with the United Kingdom. You can try to get more advanced directives, get people to think about what care they want and don't want. Those are really important interventions. And then the third thing you can do, and there's more than three, but a third thing you can do is be a little more creative about how you spend money for people when they have serious illness or maybe end of life needs. One example of this is when they loosened up what national health system money could go towards, was they said if the family, the patient, and the physician agree that this would be a good use of money for their medical needs, we're going to be more willing to allow that to happen. And an example that was quoted in the Guardian newspaper that in the UK was of a gentleman who had Alzheimer's and was often agitated. It's a very hard condition to live with when you get confused and you don't know why. You lose that sense of control. It's very tragic and difficult, right? But in this case, they used some health system money to buy him a video recorder, digital DVR, and he was able to, the son programmed it to record his favorite show, and then he could watch some of those favorite shows again and again. Because of his memory disorder, he didn't even necessarily know that he was watching it again. But anytime he was getting agitated, he could just turn the TV on, know that his favorite television show was there to watch, and it tended to calm him down. And the thought they believed, again, anecdotes, I said I'd give you a lot of data, was the money they spent on that was much cheaper than the amount of time they'd have to spend with medications and potential hospital stays or other visits for his increasing problems with agitation. So we need to be more creative about that. All right, so just quick reminder where I'm coming from. I do think that a completely free medical care system may not be the ideal system if it leads to people demanding more medical care than they otherwise would at a price we can't afford. That doesn't mean that I think we should shift to a high out-of-pocket system that people are frankly not really capable of incorporating into their own preferences to guide many of their healthcare choices. So I think we should radically rethink what kind of design we want in insurance, what out-of-pocket costs will expose people to and why. And we need to also empower them with the tools and potentially the financial resources to then better navigate that system so that they make choices that reflect their values and let them get the medical care they want at the price they can afford. That would be what I hope we can do. So again, really eager to hear your thoughts and questions. Thanks.
Thank you so much, Peter, for that presentation, and which is so relatable to myself, and I'm sure to many, many others who joined today. We've all experienced this either personally or through family members. So yeah, glad to be surfacing this, that you are surfacing this. And I think we have one question in the chat. I'll encourage others to post any questions or comments there, or just as I put in my comment, either, or you can just say I have a question or comment, and we'll go ahead and unmute you so you can share that. But yeah, it does seem like there's something like sincerely off about the balance of power and responsibility in our health system, and many different actors involved who seem to have some forms of responsibility with respect to costing, managing it, as well as some who maybe don't want to take that on for various reasons. And I think you've pointed us in the direction of some of those reasons. And I, as a lawyer, trained as a lawyer, I'm also thinking there may be liability concerns also behind the scenes here about engaging and advising in ways about finances, and that sort of presenting worries.
Liability concerns about engaging in finances, you think?
I'm wondering, I'm wondering if maybe some might think, if I start to advise someone on this issue and say, oh, this shouldn't cost you anything, or this might, that then if it comes back and turns out to be a really high cost item, that there might be concerns that will come back.
Yeah, and it's amazing how many bad decisions we make we justify from liability concerns. Yeah. And like you talk about how we overtest and overtreat in the United States, and they say, yeah, but I'm going to get sued. I'm like, okay, and so if you do an unnecessary test or procedure, you won't be sued from a complication of that. Right. I mean, so the psychology doesn't feel unbalanced. I think right now, cost-related cost issues are a huge factor contributing to non-adherence to medication and treatment. If you prescribe somebody something they can't afford, then they're not taking it, and they potentially have medical harm that will follow from that. So to not have the conversation seems that seems a lot closer to malpractice to me than to have the conversation.
Yeah.
Really clear that there are people I think it's really important when we talk to people that we don't make them feel like I'm only talking to you about money because I think you're poor. Because that is offensive, and I can understand where people are going to have distrust about that. I think we need to practice language. Like, I talk to all my patients about costs because it's hard for me to know what their insurance covers and whether they can afford it. And so that kind of language I think is really important. And I think if you have that kind of compassionate conversation with people, I think if anything, you've just reduced your chance of liability.
Yeah. Yeah. So I only get to some of the questions here in the chat. And yeah, it does seem like, insurance companies too probably have some responsibilities here that we aren't holding them as accountable perhaps as we could in terms of building in checks into the system for financial checks and the like, but maybe others want to pick up on that. So Travis here's, I think, pointing us to this fact that it's just a feature of our system, right? That people show up to the emergency room in urgent need and they get seen, and there are laws in place and TALA and things that require hospitals to stabilize them, but yet the bills still come afterwards, and it's hard to make a financial decision, obviously, in that context. But I think he's just throwing that in the mix here as an additional complexity of these questions, navigating them. I don't know if you have thoughts.
Yeah, and that's where I think that's again where a high deductible plan, that really doesn't make sense then, because that one visit might cost you $5,000. You can see why the person with crushing substernal chest pain is maybe reluctant to go in and get the care they need because they see that $5,000 bill looming. I don't think we want that to influence people. I think independent of this, because out-of-pocket costs that are what's covered is what I talked about, but what Travis might have also been getting to are some of the surprise bill problems that arise where, that person's out of network. The person who was covering the ER tonight is not part of your network. And so the full bill is coming to you. And we've seen that private equity firms have actually made that their business model. We're going to hire a bunch of people who are going to be out of network, working at all these ERs, charge up the wazoo, regardless of whether it's a colonoscopy. And I had to make a wazoo joke. And I mean, that's just deeply unethical. And it's good that we're finally seeing legislative ways to tackle that.
Great, thanks. Mike, I wonder if you want, maybe we can unmute you and you could ask your question here. Love for you to.
Yeah, please introduce yourself too.
Yeah, please.
Sure. You can hear me?
Yep.
Yeah, thanks. This was pretty amazing overview. Yeah, I was just wondering, in your opinion, so thinking about options for better aligning price and value for drugs, say, given that cost effectiveness analysis faces so many advocacy and legal barriers in this country, and then even, I know you've looked at some of the recent proposals regarding external reference pricing. These seem to raise a lot of concerns among a lot of different stakeholders, and that would allow us to just use cost effectiveness analysis from other countries. So given that these are kind of not on the table anytime soon, like what are some other options to pursue here?
Yeah. So when you talked about external reference pricing raising concerns among stakeholders, you mean drug companies?
Well, yeah, I'm not as concerned about their concerns, but
okay.
Academics, other researchers in this area seem to echo some of the concerns that drug companies have around this sort of resulting in delayed access or higher prices in other countries, so we wouldn't end up getting the benefits of their low prices right now. Just a lot of, I guess, unknowns that can be modeled, but we don't really know what will happen.
Yeah, I mean, thank you, Mike. That's super good question that I will inadequately address. And if other people have insights on it, because I know there's a lot of expertise in the virtual room here, I'm really open to that. I'm pretty happy with an approach that we try, and if it doesn't work, we can try something else. Or if it works for a few years and then they start raising prices in Australia, and then we have to come up with a different plan. We come up with a different plan, but in the meantime, we're not paying the ridiculous prices we're paying right now. Am I concerned about the rest of the world paying higher prices? not very concerned. We're subsidizing much of the developed world right now. And I think if drug companies are willing to sell a drug to Australia at a certain price, it means it's more than what it costs to produce the drug. And if that's the only price that Australia is going to let them sell it at, that's the negotiation they'll have. I think that they'll all work it out. Other concerns you talked about, though, are like, well, but that's just an indirect way of taking all what we know are unethical parts of cost effectiveness and backdooring them into the United States. I do think there are very important fairness concerns and figuring out whose lives we value and how we value them that can be baked into cost effectiveness that deserves scrutiny. I've thought a lot about that, written about it, blah, blah, blah. But I think it's so much better than the system where we're pricing people out of being able to even afford their medicines. That's got much bigger fairness concerns, especially given who's typically being priced out.
Yeah, thank you.
Thank you, Mike.
Maybe as we wait for others to raise additional questions in the chat, I'm intrigued where you kind of started, and you were, I think, suggesting or indicating that that some have tried. I don't know if some have tried this or not, but to consider the platform and consent as a modality for further communication about costs and maybe even requirements related to disclosures and the like. But I wonder if you could say a little bit more about what are some of the challenges with putting into effect more guidance or requirements related to cost disclosures through consent processes, and what are some of the pitfalls there?
Well, you are a lawyer, aren't you?
No, just curious.
But you are a lawyer, aren't you?
Yes. Yeah.
Yes. Okay. Just checking. Yeah. I have not thought about a whole lot in terms of consent requirements, maybe because I'm just dubious of a lot of that. How it gets, informed consent has become a form that you sign without understanding, rather than what should just be part of good clinical care, which is to help people understand, to educate them about their illness or conditions, to help them understand their alternatives and decide among them. That's just, to me, that's what informed consent is. Don't need a signature on a form. And sometimes when you make it a requirement and you formalize it, it can get away from the ethical ideals. I think so I don't know, I haven't thought much about disclosure requirements, but I think you should have price transparency requirements, that they should be easy to find and that people should be able to get on an app on their phone and see it, or it should be built into the EHR. So doctors, when they're ordering medicines, or nurse practitioners, can see the prices tied to that person's insurance coverage. That's called a real-time benefit tool. That should be mandated.
Yeah, great. And do you think, sorry, did I see there's another question in the Q&A, just to follow up?
Yeah.
Do you have thoughts on either through formal consent mechanisms or just conversations between providers and patients, that there are some risks related to disparities in terms of what's disclosed and to whom? And I think you touched on this early during your talk, but
yeah, and I think that's unavoidable in life, right? We strive to train clinicians that know how to interact with all patients equitably and that can somehow see beyond their biases, which we know is humanly impossible, but we strive to approach that asymptote. The alternative is to have a system where we don't talk about costs with much of anybody. And I think that actually disproportionately hurts lower income patients more, because those are the ones who can't afford the medicines and who might be too embarrassed to tell their doctor that they can't afford them and therefore go without necessary care. In one study that I did with Yusuf Zafar, but Yusuf led, we interviewed women with breast cancer, asked them about out-of-pocket costs, whether they had any financial distress they experienced from those costs. Many of them did. None of them brought up the cost of care with their doctors until they were at the breaking point. Sometimes at which point they realized they could have had a much less expensive course of therapy or could have gotten more financial assistance if only they'd not been too embarrassed to bring the topic up. And I think that kind of embarrassment might even be more common among some of our more vulnerable patients.
I see a question in the Q&A here from Judy asking, would it be reasonable if insurance companies had a cap on the amount of profit they can make, similar to utility companies?
insurance company profits are not a big problem.
Yeah.
I mean, they're actually are capped and they're regulated by the states. They typically build in a 4% profit margin if they're a for-profit. I don't even think the distinction between for-profit and nonprofit is necessarily that important. I think maybe we should look at executive pay a little more closely and put more pressure, social pressure on the people running these insurance companies to make less money. But, you know, insurance companies are there to try to drive down the cost of care. And so they're not the reason that the United States has the incredibly expensive system we have. That's because hospitals and physicians largely have a lot of power, and we join medical organizations or American hospital associations that work very hard to keep our remuneration substantial.
Yeah.
And so does pharma, by the way, and device companies and the like.
All right, so I'm not seeing any other, maybe if others have questions, please do.
I could insult doctors for making money a little bit more and see if that got any more questions.
Prod, poke and bear.
We
Yeah.
have a comment in the Q&A.
Uh-huh.
Would it be
We just got to that one, actually.
okay?
Yeah.
Okay, thank you.
Yeah, no problem. Yeah, so maybe if we could come back, just your thoughts on the
I
high
saw a question
deductible.
actually that just came up about, I think about med school
Okay.
training.
Great.
Is that
yeah,
right? Let me look,
Yep.
pull it up.
Med school training that incorporated into how to discuss cost. Yeah.
Little to no such teaching. And in fact, I think the way we teach shared decision-making in medical schools is pretty crappy. I don't think we know how to do it well. I think people come out of med school thinking that patient empowerment means give them information and ask them what they want. And then they get to practice and realize that doesn't work. The patients want to know what the recommendation is. And we haven't taught them how to navigate that at all. And so that to add the cost side to it is going to make it even more complicated, especially when we still don't have the prices even out there. By the way, just did a survey with Carolyn Sloan, a general medicine fellow here at Duke. We sent it to a bunch of internists around the country. We asked them to imagine a patient who faced high out-of-pocket costs and was giving a really expensive medicine. And the patient said, well, how much will it cost me? And then we gave them the little data sheet on the insurance plan, super simple. Here's the deductible, here's the copay insurance, et cetera, out-of-pocket max. And we said, how much would this cost the patient? Less than half the time could they answer the question. They didn't know how to interpret what a deductible was. This is physicians. They didn't know what an out-of-pocket max went, so they didn't know that when we asked about the patient who was there in November that they'd already spent out their out-of-pocket max. They didn't know what to do when the deductible was met, but the co-insurance hadn't been met. And so we can't expect to have really good conversations when medical students don't understand insurance.
Ask just maybe the obligatory COVID question, if I could. Are there ways in which accommodations have been made during the pandemic with respect to cost and coverage and things like that for certain things that you think are meaningful and helpful, or that might outlast the pandemic, or anything in that regard that you think lessons that we might learn? Other than finally getting coverage for telemedicine.
Yeah. I thought when the pandemic began that we should ban all out-of-pocket costs for medical care while the economy was in the tank and people were losing their jobs. And we made this exception, you won't get charged for COVID testing and treatment. I just said we should have just waived it. In fact, we were already stopping most routine medical procedures anyway. That would have been a great way to start that off, and then maybe that would have had some sticking power. I don't think that's going to be a big force to change things. Maybe it'll leave us in so much federal deficit that I worry that it'll actually make Medicare hoist more out-of-pocket costs on people because the federal budget will be in such disarray.
All right. Well, on that optimistic note, I think we'll close for today.
Oh,
but
man, that's terrible.
No, unless you have a more optimistic message, I'll let you.
I think everyone should check out the New Hampshire website, their healthcare pricing website, because that's what your state should do. I know Maryland has lots of interesting things about the budget, the total budget thing. So you guys have been a very innovative state. See what another really innovative state is doing, and that's what we should be pushing legislatures to do.
Great. Well, thanks so much, Peter, for joining, and thanks everybody for joining as well. Look forward to the next seminar in a couple of weeks. Thanks.
All right. Have a great day, everybody. Stay healthy.